talks. So what we're going to go over in general is a basic history physical exam for people with shoulder pain, and then kind of talk about the possible diagnoses. So in general, evaluating a painful shoulder can be very difficult. It's a very non-specific exam in many cases, and patients have a very hard time localizing where the pain is at. So in order to get a good answer in regards to what's going on, you're going to want to take a good history and physical. And in most cases, hopefully with the history, you can kind of guide yourself toward where you want to go, and then use your physical exam to kind of solidify the diagnosis. So first of all, this is a basic differential diagnosis for people coming in with shoulder pain. There's obviously a lot more than this. The most common ones are up here on your left. So rotator cuff disease is going to encompass the vast majority. Never forget about cervical spine problems. That's going to be something that overlaps a great deal. Frozen shoulder, glenohumeral arthritis, biceps pathology. We'll talk about all of this stuff a little bit. Some of the less common things are over here on the right, which we won't get into today. So first of all, in regards to the history, the number one thing you're going to look at is age. You can narrow it down a lot based on age alone. So when you have patients over the age of 50 with shoulder pain, the majority of those are probably going to be rotator cuff disease. Frozen shoulder is seen in patients between 40 and 60 most commonly. Anything under 40, normally you're going to be thinking about labral pathology, maybe biceps disease, but rotator cuff disease being very uncommon in that age group. The location of the pain is going to be very common. This is something you always want to ask, because if you don't, people are going to come in and say, my shoulder hurts, and half of them are probably going to have a neck problem. So most people with rotator cuff pain or shoulder pain are going to have pain where this is pointing here over the proximal lateral shoulder that refers down to the lateral aspect of the arm. Some of them will hurt anteriorly, maybe over the biceps, sometimes pain in the biceps muscle itself, but always pay attention to people who have pain in the back of their shoulder, around the scapula, up into their trapezius, or at the base of the neck. So night pain is another thing that's really important with shoulders. Night pain is what's often going to get people into the office. So when you can't sleep at night, your quality of life goes down, and then you want to get taken care of. Acuity, obviously fractures, dislocations, acute rotator cuff tears are things that are going to find us very quickly. But in most cases, for what you're going to see, it's going to be chronic disease, rotator cuff, biceps, and osteoarthritis type problems. So you'll want to ask people about range of motion issues if they're having problems putting on a coat, something like that. Weakness overhead can be indicative of rotator cuff problems if they had a prior dislocation or any prior injuries to the shoulder. Does throwing aggravate? Is there anything in particular that makes it worse? And you're always going to want to ask about numbness or tingling in the arms, again, because there is a lot of overlap with the cervical spine. So when you start on your physical exam, the first thing I typically do is inspect the shoulder. You're going to want to look for atrophy first, and Dr. Wateritis was talking about this, but this here is an example of rotator cuff atrophy on examination. So when you see flattening of the infraspinatus fossa here, or the supraspinatus fossa, which is just above it, there's only a few things that are going to do that, the most common of which is going to be a chronic, normally large tear of the rotator cuff. You can also see it with spinal glenoid cysts or suprascapular neuropathy. The example here on the bottom is a patient with deltoid atrophy. This is going to be a lot less common. This is a real problem because when you lose your axillary nerve, it's really hard to get a good functioning shoulder. The trapezius is another thing that you'll see on occasion, and that'll tie into this, which is scapular winging. It's another thing you're going to want to look for on a lot of people, particularly if they're complaining of pain in the back of their shoulder, a deformity of any kind. So there's two types of scapular winging. Medial winging is the most common, typically idiopathic. It's a long thoracic neuropathy. Picture on the bottom is an example as well. It's a little more prominent. Spinal accessory nerve is how you get lateral winging and trapezius atrophy. This is every time I've seen it, which is probably 3 times, it's been a complication of neck surgery. Next thing you'll want to do is check their range of motion. You're going to want to do this in every patient. So the way I do it, I check overhead, forward flexion, external rotation at 90 degrees, external rotation at the side, and internal rotation behind the back. You're going to want to compare passive and active range of motion. So if you have passive loss of motion, you're going to be dealing with either a frozen shoulder or an arthritic shoulder most likely. If you have full passive motion but have lost active motion, that's typically from muscle weakness, and you're going to have patients typically with rotator cuff tears. You're also going to look for painful arc or shrug sign. This down here is a shrug sign where a patient has to compensate to lift his arm up. This is typically a sign that they have a great deal of pain. Over here on the other one, this is an example of a painful arc. So the pink or shaded in area in a patient with, for example, a rotator cuff tear with a painful arc, that's the area where it's going to hurt. Lots of times when they get above 120 degrees of forward flexion, their pain will get better. Instability, this is a little more geared towards specific patients. I don't check this on everybody, but if you have a younger patient, something you're going to want to check. The apprehension test is the most common way to do this. The top up here is a good example of this, where you get the arm in abduction and external rotation, stabilize the scapula, and pull an external rotation force. A truly unstable shoulder, these patients will say my shoulder feels unstable or like it's going to dislocate, not necessarily pain. Pain can indicate other things. Posterior instability, here's an example of this here. It's where you bring the arm up into forward flexion and adduction and apply a posterior force to the shoulder. Again, a truly positive test is when they feel like the shoulder is unstable. Sulcus sign over here where you pull direct pressure down and you can kind of see the widening between the humerus and the acromion here. When you get that, again, there are a lot of patients with loose shoulders who will have this, but a true positive sulcus sign is if they get symptoms when they get that. So you always want to palpate the shoulder as well. This shows some of the spots, but these are basically the areas that I palpate on every exam. I start with the sternoclavicular joint, which is typically be normal. You always want to palpate the AC joint. Greater tuberosity is where most of the patients you see are going to have pain, which is right here over the anterolateral aspect of the shoulder. That's consistent with rotator cuff disease in most cases. You always want to palpate the trapezius and periscapular musculature in most of those patients. If they're tender there, you want to start thinking about the neck. Next is strength testing. So for rotator cuff disease, this is extremely important. This is going to kind of guide your next step in care. So you're always going to want to test strength in abduction and external rotation. Weakness in these areas is frequently consistent with a torn rotator cuff. If you have weakness in internal rotation, which is much less common, you start thinking about subscap and biceps problems. The shoulder has a lot of internal rotators that are much stronger, such as the pec and the latissimus. So if you're having weakness with internal rotation, it's normally a sign of pretty significant pain. Lag signs are a sign of even more weakness, where a patient basically has less than anti-gravity strength. Drop arm test where you hold the arm up to 90 degrees and they can't stabilize it. External rotation lag sign when you bring the arm out like this and they can't hold it out here. That's typically a sign of a massive tear of the rotator cuff. This is a long list of provocative tests. We won't go through all these. There's a whole bunch of them. Mears and Hawkins tests are some of the more commonly used ones, which are the impingement tests seen in patients with rotator cuff tendonitis. Speed's test and Jurgensen's test are used for the biceps. Jurgensen's is actually one when positive, which is basically resisted supination of the forearm. When that's positive, normally they're going to have a biceps problem, but it rarely is positive. We'll talk about O'Brien's test a little bit later, which was another one that I frequently use. So when you examine patients who come in with shoulder pain, the first thing that I'm trying to figure out is it truly a shoulder problem or is it a neck problem? And in my practice, I would say at least 1 out of 3 new patients who come in with shoulder pain, there's at least a suspicion that they might have a neck problem. So always ask where it hurts. Is it proximal lateral shoulder, lateral arm, or is it up around the shoulder blade and into the trapezius or posterior shoulder? Are there radicular symptoms? Is there numbness and tingling? Does the pain go beyond the elbow? Classically, shoulder pain should not extend beyond the elbow, though in certain cases it certainly will. But if the pain goes beyond the elbow or there's numbness or tingling, you definitely want to think about the cervical spine. When you examine people, when you have pain-free range of motion of the shoulder, the odds are they probably don't have a shoulder problem. Tenderness over the trapezius, limited neck range of motion. I do a Sperling's test in everybody, which is where you have them look up, turn their head to the side, and apply an axial load to the top of the head. And if that reproduces their symptoms in the back of the shoulder, I would start thinking about their neck. And in many cases, especially for what I see, sometimes it's really hard to tell. And what I do in most of those cases is give them a diagnostic cortisone injection in the shoulder, and if it gives them relief, it certainly steers you more toward the shoulder. So once you've delineated that it is a shoulder problem, far and away the most common cause of shoulder pain in most of the patients you're going to see is rotator cuff disease. At rough numbers, at 50 years of age, at least about 10% of people are going to have at least a partial thickness cuff tear. At age 70, about 50% of people will have at least a partial thickness cuff tear. Dr. Wateritis had already talked about so we won't go over it too much, but basically on the history, these people are typically going to be older than 50. You should not be seeing 30-year-olds with rotator cuff pain, at least not very often. They may have night pain. Again, it's going to hurt in the proximal lateral shoulder, down the lateral aspect of the arm. In most cases, it's going to start as an atraumatic problem and gradually get worse over time, and the patients are going to complain about difficulty with overhead activity. On exam, normally they're going to have full motion. Early on in the process, when they have tendinopathy, tendonitis, bursitis, whatever you want to call it, they're probably going to have full strength. They will probably have positive impingement tests. They'll be tender over the greater tuberosity. When you get an x-ray, here's one thing you want to look for. So this is the shape of the acromion right here. So you'll see a big spur coming down right there, which is not normal, and that's typically a sign of rotator cuff disease. Other than that, you're not going to see too much on an x-ray. The next step up is torn rotator cuff. So the big difference here is that on exam, you're going to start to see weakness. So when they have weakness in abduction and external rotation, you're probably going to want to pursue it a lot more aggressively. You'll test the subscap2, which is a belly press test, weakness and internal rotation. But more often than not, what you're going to see in your office is weakness and external rotation, which is your number one warning sign. They'll start to get painful arc, shrug sign. An important question to know is, when do you get an MRI? I agree for the most part with what Dr. Wateritis said. I think anyone under 60 with weakness, I would be very liberal in getting an MRI. When they're a little older, pushing 70, 75, I would probably start with conservative treatment first. But certainly in a younger patient with weakness, I think it's a reasonable thing to do. Next step up is rotator cuff arthropathy, which you're going to hear about later. So I won't go into it too much, but this is basically severe rotator cuff disease. These patients will have pseudoparalysis, positive lag signs. They'll get crepitus or ratcheting with range of motion, and pretty significant rotator cuff atrophy on exam. When you look at your x-rays, the two on the left are good examples. These are high-riding humeral head. The undersurface of the acromion is abutted by the humeral head. I just found this picture and thought it was interesting. I've never seen one like that, but if you see that, I'd probably run. Next is a frozen shoulder. So frozen shoulders are a diagnosis you should be able to make in the office every time based on your clinical exam. Something that when you see a lot of gets really easy, and when you don't see much of it can be a little bit harder. So a frozen shoulder is a complete loss or a global loss of range of motion, both passively and actively, typically idiopathic. When you see a 40 to 60-year-old, typically often women, diabetics with severe pain, limited range of motion, this should definitely be the first thing you think about. It's typically gradual in onset, can be extremely painful. They'll say the same thing every time. I have a hard time putting a coat on when I reach into the back seat of the car. And again, the pain is normally in the proximal lateral shoulder where most shoulder problems hurt, although this has a little bit more variety in my experience. But when you diagnose this is something you should be able to do when you watch a patient lift their arm up. When they go to lift their arm up and they only get to about here and it hurts a lot, and then you go to push on it more and it doesn't go any farther, that's frozen shoulder. Well, it could be arthritis too, but normally it's a frozen shoulder. But nothing else is going to do that. It's only going to be a frozen shoulder arthritis that makes you limit your motion in that way. They'll have a shrug sign, they'll have normal strength, and if you get them to the extremes of motion, it's going to hurt a lot. X-ray is going to be normal. I see a lot of these people who say they really, really want an MRI because they hurt so bad, but they don't need it. I mean, it's a clinical diagnosis, and you should be able to pick it up on your exam. So next we'll talk about biceps problems. This encompasses a fairly large range of things: superior labral tears, biceps tendonitis, biceps subluxation. It's a common cause of shoulder pain in younger patients. So if you have someone under 40 who has shoulder pain, this is something you're definitely going to want to think about, particularly in throwing athletes. It's something you're going to see a lot of in patients older than 42, but that's typically a degenerative change and often associated with rotator cuff disease. The pain, again, it's a little variable, but anterior shoulder, proximal lateral shoulder, and sometimes it refers down into the biceps muscle. Here's an example of a superior labral tear here. It's nicely labeled already, but here's the biceps, superior labrum, and your glenoid. And this tissue here should be attached down here, again indicating a tear of the superior labrum. This is a difficult problem to pick up on examination. It's very nonspecific, and there's really not a great test to do that. Just some things to look for. It often causes pain with an apprehension test. I would definitely do Speeds and Jurgensen's test. Speeds is down pressure with the palm up. Jurgensen's is resisted supination of the forearm. The one I use most, and especially in younger patients, is O'Brien's test. O'Brien's test is forward flexion, pronation first, again resisted force down, and then do it in supination. And a truly positive test is going to hurt more when it hurts more in pronation. X-rays are normal. Another thing to keep in mind, and Dr. Wateritis talked about this as well, but you're going to see slap tears on lots and lots of MRIs. So if the patients are over 50, very commonly that's a normal degenerative change of just the aging process. If you see a slap tear in someone under 40, you probably have a problem. Next is glenohumeral arthritis. This is something you're going to hear about more later too, so we'll keep this brief, but this is a lot less common than rotator cuff disease. Gradual onset can be very limiting functionally. You'll hear ratcheting, grinding of the shoulder when it moves. And again, if you have somebody who's lost passive and active range of motion, it's either going to be this or a frozen shoulder. AC joint pain, this was touched on briefly as well. The one thing I can tell you about AC joints, if you ask someone where do you hurt, they'll take one finger and they'll point right to the AC joint. That should be almost a giveaway as to what the diagnosis is. It's not very diffuse. It'll sometimes refer up into the trapezius, but normally it's a very straightforward thing. Now that's typically easier to do in a younger patient, typically weightlifters. In older patients who have rotator cuff disease, it'll often come along with a multitude of other problems. But if you're seeing younger patients who localize pain to the AC joint, they're probably going to have some arthritic change in the AC joint or what we call osteolysis of the distal clavicle. On exam, to elicit pain in the AC joint, you're going to do cross-arm adduction. You'll get pain with forced internal rotation when you bring the arm up behind the back. Hawkins test is often positive. And this is an example on x-ray of an arthritic AC joint with joint space narrowing and bone spurs. So the last thing we'll touch on is calcific tendonitis. This is something that will come into your office from time to time. It causes severe pain. Can't move, extremely painful. There's not many things that can do that. If someone comes in with basically an immobile shoulder held in a sling position, they're going to have calcific tendonitis. They could have brachial neuritis, which is a rare condition. They could have a septic shoulder. But 99 out of 100 of these are going to be calcific tendonitis. And when you get an x-ray, you'll see this big glob of calcium up here. These are almost always non-surgical. You can almost always get them better. You don't need an MRI. The x-ray gives you the answer, and a cortisone injection will normally get it better pretty quickly. And that's it.